All right, guys, chapter 35, shock. Now, I know last semester we did talk about shock just a little bit right there at the end. We will go back and recap on that, and that's compensatory measures of shock. But this chapter is located, like I said, in chapter 35 of your book, and we'll get a little bit more in-depth into shock, and we will revert back to that PowerPoint and that kind of freelance class we did right there at the end of last semester. All right, so what is shock? Shock itself is not a single event, and it does not have one specific cause. Therefore, it does not have one specific treatment. Rather, it is a complex physiologic process that results from a variety of abnormalities that can result from injury, illness. There's also a bunch of complexities involved in shock. It is not adequately defined by pulse rate, a blood pressure, and cardiac function. Meaning we can't just look at a blood pressure, we can't just look at a pulse rate and say, oh, they're in shock, all right? We kind of have to understand everything that's going on and use those visual cues, so to say, to figure out what the patient is in, whether they're shocked, and if they are in shock, what type of shock. Now, shock may infect the entire body, or it may occur just at a particular tissue or cellular level. And this can take place even with normal hemodynamics, meaning the patient just walking around right there in front of you doesn't appear that sick, can actually be in the early starting stages of shock. At its fundamental core, shock is hypoxia at the cellular level. Thus, understanding the cellular physiology is needed to recognize the more subtle aspects of shock. Cells require oxygen for the production of energy by the means of aerobic metabolism. Systemic oxygen delivery to the tissue depends on two factors. One, the adequate delivery of blood through the capillary beds in the tissue. This is perfusion. And adequate oxygen content of the blood. For there to be effective tissue perfusion, oxygen supply and oxygen demand must be in balance. So there's where we go into, are we in aerobic metabolism versus are we in anaerobic metabolism? So if we go to that anaerobic metabolism state, which means we're without oxygen, the cellular demands are still there for oxygen. But however, the cellular delivery is not there. So that's what takes us from the aerobic metabolism to the anaerobic metabolic state. Achieving this balance requires a proper functioning of the heart, the vasculature, and our lungs. All three of those work together. Our heart. Systemic oxygen delivery is the product of cardiac output and arterial oxygen content. So cardiac output depends on several factors, including the strength of the heart's contraction, that is known as inotropic, the rate of the contractions, which is known as chronotropic, and the amount of venous return available in the ventricles. This is preload. Now, we talked about preload in cardiology, and I told you the best way to remember preload is the amount or the volume of blood coming back to the ventricles from the venous system. Keyword there, venous system. We know that the formula for cardiac output is heart rate times stroke volume, as we see right here. Now, usually the first thing that the body does when it senses a decrease in cardiac output, because it's the easiest thing to do, is increase our heart rate. Because we'll notice that usually the early stages of shock are due to this decreased stroke volume. So the body has the ability to increase its stroke volume, but it's easier to increase the heart rate to compensate for that lower stroke volume. When oxygen delivery is inadequate, the first compensatory response, like we said, is to increase that cardiac output. And we do that by increasing the heart rate or the stroke volume. Again, usually you see it quicker in the heart rate section because that's easier done. So some important terms that we need to understand in the cardiac physiology and shock are preload, afterload, and mean arterial pressure. We know, as we talked about just a second ago and from previous cardiology, preload is the ventricular volume at the end of diastole. This is driven by your venous return. Again, we go back to first semester in cardiology. Preload is easily understood as the amount of volume, aka blood, in the ventricles or coming back to the ventricles via the venous system at the end of diastole. Afterload is the resistance that the blood must pump against. Now, a lot of people think, all right, well, then preload is the amount of volume coming back into the ventricles at diastole. Then afterload has to be the amount of volume coming out during systole. No. Afterload is the total resistance against which blood must be pumped. Now, total peripheral vascular resistance is determined by the volume of the blood in the vascular system and the diameter of the vessels. And that plays a good bit into afterload, but we're going to talk about that a little bit later. Mean arterial pressure, also known as MAP. MAP is the function of cardiac output and systemic vascular resistance, SVR. MAP's mathematical formula is cardiac output times stroke volume. Now, we have no way of doing that in the back of the ambulance. I understand that. But we will teach you a formula that you can do to get you a MAP. Now, MAP is the driving force of resuscitation. You're going to hear us utilize it in neurology. You're going to hear us utilize it a lot in the shock setting. We're looking for that tissue perfusion to take place at a MAP around, according to what literature you read, I like the 65 to 70 mark. MAP represents the average pressure in the vascular system at any given time. Because more time is spent in diastole than a systole, MAP is not just the average of diastolic blood pressure and systolic blood pressure, but rather reflects the relative time spent in each portion of the cardiac cycle. Again, driven off the diastolic, your MAP formula is diastolic blood pressure times 2 plus your systolic blood pressure divided by 3. So let's do it out real quick. Say we got a patient that's got that perfect textbook blood pressure. They got a BP of 120/80. So if we do this out, mathematically speaking, diastolic times 2, so 80 times 2 plus 120. That gives us, the 120 is our systolic, that gives us 280, and then we divide that by 3, and that gives us a MAP of 93 millimeters of mercury. So that's how that's figured out. Now, you can do that in the back of the truck relatively easy. If you're using some of your newer monitors on your NIBPs and even on your invasive blood pressure monitoring, you're going to see a little number below your blood pressure, and it's going to be in parentheses. That is your MAP. They're usually relatively accurate, but I urge you to do the formula real quick. Everybody's got a smartphone in their pocket nowadays. Pull your calculator out, do it real quick, and make sure it's accurate. And another thing you got to think of too on those NIBPs, that MAP is only as accurate as that blood pressure is. So if your blood pressure is not reading right, meaning you've got your patient on multiple vasopressors and you're still getting low pressure readings, you got to think about it. Vasopressors cause vasoconstriction, so we start shunning that blood away, can alter your NIBPs a little bit. So again, if you got a sick patient, it's always better to get you a good actual manual BP. All right, so injection fraction. So again, we mentioned injection fraction a little bit in the cardiology section. This is a measurement of the percentage of blood volume pumped out of the left ventricle with each contraction. Normally, 50 to 70% of the blood is ejected out of the left ventricle. Remember now, think of your heart as a pump. What must a pump stay? Primed. So that's why you don't eject every bit of the blood volume that the left ventricle has in it, because we need to keep some volume in there to keep that pump primed up. So normal EF is 50 to 70. Now, a borderline ejection fraction of 41 to 49% is starting to get low. That's the ones your patients are looking at and we're like, you got these early symptoms of congestive heart failure, some other cardiac abnormalities or so on. So this is starting to draw some attention. Again, this is not stuff you're going to see in the back of an ambulance. However, you might be transferring a patient, you're looking through that chart, and you will be able to pull this information through that chart. And it also gives us a better view on this patient if we have that information available, because we're kind of expecting to see what type of hemodynamic status this patient is in normally. Now, when the ejection fraction begins to go less than 40, tissue perfusion will be compromised. All right, so vasculature. So blood flow to an organ is dependent on three main factors. Getting to those factors before we get ahead of ourselves. The entire vascular system of the body is lined with smooth, low-friction endothelial cells. All vessels larger than the capillaries have tissue layers surrounding that endothelium known as tunica or tunicate. It depends on where you're at and how you want to say that. These layers provide supportive connective tissue to counter the pressures of the blood contained inside that particular vascular system. They also have elastic properties that enable these blood vessels to dampen the pressure by dilating when we have that increased pulsation and to minimize flow variations throughout the cardiac cycle. Also, these tunica have muscle fibers that allow them to contract and reflex to control vessel diameter. This vascular system maintains blood flow by changes in the pressure and peripheral vascular resistance. So one of the easier ways that we can control these pressures is through vasodilation or vasoconstriction. Now, again, we talked about this in the past through our sympathetic nervous systems and all, and we'll briefly touch back over that here in just a second. All right, so SVR. Like I said just a second ago, blood flow to organs is dependent on three main factors: arterial pressure, venous pressure, and vascular resistance. Now, the formula to understand this flow is your arterial pressure minus your venous pressure divided by your vascular resistance. However, you will never have that information in the back of an ambulance on your standard run-of-the-mill ALS call. But that is how it's determined. Now, understanding what that is a different story. Excuse me. Changes in resistance that are primarily means by which blood flow is regulated within the organ. So what that means is changing the resistance in which blood must flow affects that organ perfusion tremendously. On a systemic level, afterload, remember what afterload is the total resistance which a blood must be pumped against. That's also known as systemic vascular resistance. Don't get it confused with peripheral vascular resistance. Think about it like this. Blood is pumped out of the left ventricle, into the aorta, into the systemic vascular system or systemic circulation. So afterload and systemic vascular resistance is the same thing, and that is the total resistance against which blood must be pumped against. It is determined primarily by the changes in the diameter of the arterioles. Arteriolar constriction raises the MAP. Remember what the MAP is, mean arterial pressure, by preventing the free flow of blood into the capillaries. Because if it just flows down in there, there's no pressure driving that. And you got to remember, and we're going to talk about it here in just a little bit too, the driving force behind tissue perfusion and cellular perfusion is pressure gradients. Excuse me. So, whereas dilation has the opposite effect, and it allows the blood to flow down in there, that decreases pressure. Now, all this is a response to some outside stimulant, whether it be a medication or whether it be a illness or so on. The reflex control of vasoconstriction and vasodilation, like we just said earlier, is done by that sympathetic nervous system. So our systemic vascular resistance is the measurement of friction between the vessel walls and the fluids. And between the individual molecules of the fluid themselves. Excuse me. Both of which can oppose flow. When the resistance to flow increases, blood pressure must increase for that flow to remain constant. Resistance to blood flow increases when you have massive vasoconstriction due to a medication, or you can have a blood viscosity is thickened. All this viscosity is a physical property of a liquid that reflects the degree of friction between the components of the molecule. So big fancy terminology for they got some thick blood. All right, viscosity normally plays a minor role in blood flow regulation because it remains fairly constant in a healthy person. However, in your sicker people, this can cause an issue. Vessel length in the human body also remains fairly constant, and we know the longer a vessel is, the longer a pipe is, to maintain that water pressure at the end, you got to have more pressure at the end. At the other end. Vessel diameter, however, is the main affecting factor behind resistance of blood flow, and that's also one of the easier ways that the heart can control in a normal person pressure, is by controlling the diameter of the vessel itself. So the major arteries in the body are quite large and therefore offer little resistance to flow unless they have an abnormal narrowing or an outside opposing force causing them to constrict down. Now we know that abnormal narrowing is stenosis, okay? But now as we move into our arterioles, remember, arteries, arterioles, they're much smaller than our larger arteries, and therefore they offer the major resistance of blood flow. So a lot of times when our arteries are causing the increase in the pressure, it's not really done at the large artery section, it's more so done in our arterioles because they're smaller, therefore offering an opposing force for that systemic blood flow to move. The smooth muscles of the arterial walls can relax or contract, changing that diameter inside the arteriole as much as 5-fold. So it can take the pressure and take it up or take it down relatively quick. Again, we're talking about a healthy person here. And that's why you walk around in a non-shock state, so to say, when you're actually have the precursors for shock. So vasoconstriction or vasodilation of the vessels primarily regulates our arterial blood pressure. Now, we know that fluid flows in response to pressure gradients, no matter what it's flowing in. We're going to go from an area of higher concentration, i.e. pressure at this end, to an area of lower concentration, lower pressure. Take your water hose, your fire hydrants, or your firefighters, all right? That pressure is higher at the end where the pump is. The pressure is lower at the end where the opening of the hose is. So therefore, the water is going to move that direction because of pressure gradient, higher at this end, lower at the other end. Rather than the absolute pressure in the tube that determines that flow, it is that pressure higher at one end than lower than at the other end. All right, so you've heard me talk about systemic versus diastolic pressures, especially more so in like our heart failure patients. You have systolic heart failure, and then you have diastolic heart failure. Now we have what we call systemic pressure versus pulmonic pressure. pretty self-explanatory. Remember what I always told you, right? The problem will show its face. The problem is always behind the showing factor. So like in left-sided heart failure, okay, it shows its face in the lungs. So therefore it's the left-sided heart failure. And I actually said that backwards, guys. I do apologize. The problem, the failing problem, say in left-sided heart failure, the left side, it shows its face behind the problem, therefore the lungs. I get it out. Sorry if I made any confusions there. So systemic blood pressure. What is systemic blood pressure, systemic pressure. What is systemic pressure? It is pressure on the left side. Where does the left side pump to? To the system. Systemic. All right. Your pulmonic pressure, that's your right-sided pressure. Where does it pump to? To the pulmonary system. And the measurements of pressure in the vascular system. Now, both types of pressures have two phases. This shouldn't be new to us, systolic and diastolic. Okay. Now, the difference between these two pressures is what we call a pulse pressure. Pulse pressure is more sensitive to changes in perfusion than is the systolic pressure or the diastolic pressure alone. So what you're saying is, there you can look at that and you get a pulse pressure and you can start trending that pulse pressure and go back to like our Beck's triad and stuff like that. We talked about cardiac tamponade. You start looking at that narrowing pulse pressure. Okay, there's where that starts coming in. You start looking at that widening pulse pressure. That lets you know you're starting to kind of lose out this volume and so on. All right, microcirculation. Microcirculation refers to the circulation of blood flow through the smallest vessels in the circulatory system, hence microcirculation. And this is your arterioles, your venules, your shunts, and your capillaries. Microcirculation exists in all tissues and organs except for your cartilage, your epithelia, your cornea, and the lenses of the eye. The microcirculation of the body is divided into pulmonary microcirculation and peripheral microcirculation. Excuse me. Separate pumps, the right side of the heart and the left side of the heart, respectively produce pressure in each one of these divisions, as far as talking about your pulmonary side of your microcirculatory system or your peripheral side of your microcirculatory system. All right, so the following mechanisms control blood flow through the tissue. You have local control of the blood flow by the tissue itself. Nervous control of the blood flow. You have your baroreceptor reflexes. You have your chemoreceptor reflexes. And again, that kind of goes back to that little PowerPoint I put up at first at shock. And it kind of talks about where those chemoreceptors are located, baroreceptors are located, and how they respond inside the body to increase or decrease blood pressure by causing an activation of the sympathetic versus parasympathetic nervous system. You have your central nervous system ischemia response. You have your hormonal mechanism, and that kind of, again, goes back into that shock little podcast we did there at the end of last semester. Adrenal medullary mechanism, talk about it. The renin-angiotensin-aldosterone system, we talk about it. The vasopressin mechanism, we didn't get very in-depth in the vasopressin mechanism. We will at a later date, just not right now. And then again, reabsorption of tissue fluids. And that kind of goes back up there with the adrenal, medullary, and the renin-angiotensin-aldosterone system. Lungs, last one. Tissue cells require adequate oxygen to function. To ensure that they obtain the needed oxygen, adequate oxygen must be available to be picked up by the red blood cells as they pass through the capillary membranes. In the lungs, the high partial pressure of oxygen in an expired air, the adequate depth and the rate of ventilation, and matching of pulmonary ventilation and perfusion makes oxygenation possible. So what that's saying is the high partial pressure of oxygen. So we take a deep breath in, That's 21% oxygen, right? So we got a partial pressure of the 21% is 0.21. Well, that's greater than the amount of pressure inside the vascular system, inside the lungs at that time. So therefore, that pressure gradient, oxygen is going to push into that cell. Another thing that has to be there is we got to make sure we got the proper volume, got the proper depth. That's all great. The other side of that is we've got to make sure that, one, we've got the red blood cells there. We got to make sure we've got the driving pressure on the right side of the heart to get the blood to the lungs and then back to the left side of the heart. All right, the body as a container. So the healthy body can be viewed as a smooth fluid delivery system inside a container. It's smooth fluid flowing. This container must be filled to deliver the appropriate amount of fluid, aka blood, carrying oxygen. So it must be filled to achieve adequate preload and tissue oxygenation. If the volume decreases, but the container stays the same size, that's your hypovolemia. The pressure in the container will drop, and that causes our hypotension. So the external size of the container of any human body is relatively constant. So our container, aka our body, our vascular system, pretty much stays constant. We do grow, it gets bigger as we grow, but our body adjusts to that and our vascular systems and all adjust to that as we go through. Yet the volume inside our container is related directly to the diameter of the resistance vessel. So we can actually change the amount of fluid inside our vessels. Now, we don't purposely do that. The body can, to get rid of fluids, so if like our pressures are high and all that, we can actually create urine to get it out and so on and so on. It goes back to that renin angiotensin aldosterone system, the adrenal medullary mechanism. This diameter change in the vessels is the quickest way that we respond to that, whether it be too much fluid or not enough fluid inside the vessels. The volume of the fluid that the container holds itself does affect our preload. And remember, think preload as the amount of volume coming back to the ventricles. So let's say we got a 5-liter container. The normal container size for a adult male, roughly 70 kilograms, your book says, that's not a Mississippi unit, is about 5 liters. So preload is adequate. With a strong heart, cardiac output, and perfusion are adequate. We got a good normal blood pressure. Now, if 2 liters of that is lost, so now we've taken that 5 liters that's normal down to 3 liters remain, whether it be an external loss or an internal loss, the 3 liters that remain will be inadequate to supply the effective preload to the heart to maintain cardiac output. Because the cardiac output depends on that preload, a decrease in preload notably decreases the cardiac output. Therefore, the patient is technically hypovolemic, and the 5-liter container remains the same size despite the 3-liter volume. The patient becomes hypotensive or loses pressure in the container caused by decreased cardiac output. However, if we take that 5-liter system container and we shrink it down to compensate for that 2-liter loss, now to turn that 5-liter container into a 3-liter container via vasoconstriction, then that 3-liter container can provide adequate preload for the heart with only the 3 liters available at that time. Now, this will be done, but it's not at the expense of some tissue. So what I'm saying there is we will lose blood flow to some tissue. What's that called? Shunting. So that's kind of what we just talked about there. I got ahead of myself. I do apologize there. So, some causes of vasodilation include cardiac and blood pressure medications, allergic reactions, heat and cold related injuries, and alcohol or drug use. That's your common causes of vasodilation. So that means that's when your container's gotten bigger. Not necessarily a fluid problem, it's a container problem. So no matter what what causes shock, this condition is characterized as or by a homeostatic vasoconstrictor response with the arterial narrowing, a reduction in the number of open capillaries, and a decrease in the venous return and cardiac output. So without treatment, anaerobic metabolism will develop. Remember, anaerobic metabolism is the changing from aerobic, which is with oxygen, to a metabolitic state that does not have oxygen available. So therefore, it burns a different fuel source, which causes a different byproduct. We know that's lactic acid. The byproduct of aerobic metabolism, CO2. That's why we expel CO2 out of our lungs. Now, this increase in lactic acid produces metabolic acidosis. Severe microcirculatory failure cannot be remedied with fluid replacement. You can have capillary engorgement. They can constrict down so much that we're losing blood flow to that area completely. The capillary engorgement and the clumping of red blood cells, that affects the nutritional flow and removal of metabolic waste. Blood begins to coagulate in the microcirculation, and we have a condition, what we call disseminated intravascular coagulation, also known as DIC. Eventually, the cells begin to swell and die, and you'll start having small areas of infarct known as microinfarcts. They develop in the organs and set to the stage of pulmonary edema, respiratory failure, and acute respiratory distress syndrome to develop. If shock and DIC continues, the patient progresses to multiple organ failure, also known as MODS. In some of the older medics, you'll hear them call it MODS, which is multiple organ dysfunction syndrome. If cellular necrosis damage enough of the vital organs, the organs themselves will soon fail. Failure of the liver and kidneys is common and is often present early in the final stages of shock. Like we just said a while ago, severe microcirculatory system cannot be remedied with fluid placement alone. Eventual outcome includes heart failure, or GI bleeding, sepsis, severe pancreatitis, pulmonary thrombosis, so PEs, respiratory failure, and then death will occur if those are not treated. And usually once your patient starts going into your MODS, so to say, your multi-organ failure, then death is relatively imminent at that point. All right, so our stages or classifications of shock. Excuse me. So, like I said, the major classifications of shock, which differ by the etiology and the clinical presentation, are hypovolemic. Now, your book mentions hypovolemic, and then they got hemorrhagic in parentheses. Don't think that you have to be bleeding to be in hypovolemic shock. All hypovolemic means is inadequate circulating volume. Now, you can have decreased blood volume or you can have decreased fluid, and that's because they go together, and we'll get into that a little bit more. But don't think that you have to be in hypovolemic shock due to bleeding. You can be severely dehydrated and cause you to be in hypovolemic shock. Another one is cardiogenic shock, obstructive shock, and distributive shock. Now, there's several things that can cause those, and we're going to talk about those more in depth. And I'll probably also do a slight, small little presentation on each one of them to give you a better idea of them. Although these classifications are separate and distinct, more than one type of shock can occur at the same time, and one shock can cause another shock. So again, regardless of the classification, the final common defect in any of these shocks is hypoxia at the cellular level. All right, hypovolemic shock. Hypovolemic shock is probably one of the most common forms of shock. This is due to an inadequate circulating blood volume. Now, the blood cells and all might be present. It might just be down on the fluid side of it. So just think of it as fluid down. The most common cause is hemorrhage and dehydration. Illnesses and injuries that can lead to hypovolemic shock include trauma, gastrointestinal bleeding, which is a very common one, burns, diarrhea, vomiting, endocrine disorders, DKA, HHNK, and internal third space loss, such as peritonitis, when we start doing those fluid shifts and stuff like that. Now, our most common scene where we see hypovolemic shock is usually in our trauma patients. But again, don't get fixated that your patient has to be bleeding out to be hypovolemic. Let's go back real quick. All right. So when circulating blood volume, aka preload, decreases, the first response in hypovolemic shock is tachycardia. Now, I said that at the beginning, and you're going to hear me relating to that a lot throughout this chapter and throughout school. When you usually ask people what are some of the first signs of shock, they're like low blood pressure. Actually, you're going to learn that low blood pressure is a late sign of shock. One of the earliest signs of shock is tachycardia. Remember what I told you earlier. The easiest way that the body can compensate for that decrease in cardiac output, what's the formula for cardiac output? Stroke volume times heart rate. One of the easiest and quickest ways to compensate for that drop in cardiac output is to increase that heart rate. As shock becomes a little bit more severe, blood pressure is maintained by an increase in systemic vascular resistance, leading to a narrowing of the pulse pressure. Okay? Thus, narrowing of the pulse pressure is one of the early clinical signs of compensated shock. So you have to go in there and look, and this is a trend thing. This is not one you're going to look at right out the gate and say, oh, that's a narrow pulse pressure. Now, you got to trend it. You got to see, is it really narrowing? Because that initial one might be this pressure and the next one might be this pressure, and you see it trending up. That's a good thing. Not for the patient, I hate to say it like that, because the patient is showing signs of shock. That's a good thing for us because that lets us know we're in the relatively early stages of shock. However, when we start seeing that pulse pressure trend out, that's a bad sign. That lets us know we're on the backside of this. Things are not doing as well for the patient. Finally, the body is unable to use the compensatory mechanisms to maintain blood pressure, and there's a drop in the blood pressure. And then at that point, in-organ perfusion begins. And this is uncompensated shock. And you might hear some of the older people call it decompensated shock. All right. So, cardiogenic shock. Cardiogenic shock is the result of a severely compromised cardiac output, such as inadequate tissue perfusion occurs despite an adequate amount of circulating blood volume. So what do we know about cardiogenic shock so far? It is not a volume problem. Okay, it's a pump problem. Cardiogenic shock can result from pump failure. Can be caused by MI. It can be caused by chronic heart failure. Trauma can be caused by cardiac contusions. It can be caused by myocarditis. Numerous different things can cause it. So this Pump failure causes depression of cardiac contractility, your mechanical obstructions to forward blood flow, or the regurgitation of the left ventricular output. So sometimes you might have a narrowing of the aortic stenosis, or you might have aortic stenosis, which is narrowing of the aorta, and the left ventricle's having a hard time pumping against it, and we're not getting as much blood out. So the heart's got the fluid there. The left ventricle's trying to push that fluid out, but it can't due to that abnormal narrowing. The most common cause of cardiogenic shock is MI. And we talked about that when we covered 12 leads. Okay. With this type of shock occurring approximately 5 to 6% of all patients hospitalized following an MI, the associated mortality rate in these patients go from 48 to 74%. The risk factors for death include older age, underlying coronary artery disease, so multiple MIs in the past, that patient that sat there on the chest pain for numerous days, the infarct's already set in, the damage is already done, and so on. This will cause a decrease in ejection fraction, have elevated serum lactates levels, and evidence of brain and kidney dysfunction towards the end. Now, cardiogenic shock is commonly known as cold shock because in the face of the inability to increase cardiac output, the blood pressure is maintained by increasing vascular resistance and shunting blood to the central circulation. So clinically, the process results in cold extremities and delayed cap refill. Now, that also depends on what type of cardiogenic shock you're looking at. Sometimes you have your right-sided heart failure where your patient is pooling blood in the extremities. You have your JVD, your pete-edema, and all that, where they're kind of exploded up and warm and all that. However, if you're on the left side heart failure where that left ventricle is failing, then you start having that constriction. That's where you got your wet lungs, but you're not having the pitting and edema and all that. So don't put a lot on that. You're going to hear that cold shock, hot shock, and so on. Obstructive shock is a form of shock associated with the inability to produce adequate cardiac output despite normal intravascular volume and myocardial function. So what that means is the volume's there, the pump is working, something is blocking it. Obstructive. Okay. Some causes of obstructive shock include pericardial tamponade. That directly impairs the diastolic filling of the right ventricle and some on the left ventricle. You see it more on the right ventricle because it's less musculature. It doesn't have as much muscle there, so it doesn't push it as hard out. So it's able to collapse a little bit easier. Remember, every time that ventricle pumps blood out on the left side and on the right side, that pressure just increases inside that pericardial sac and it squeezes down. Again, it obstructs the blood flow. Think of it like this. It's not a blood volume problem. It's not a pump problem itself. Yes, I just said the volume is decreased because of an opposing force on the heart, but the heart itself is not failing. The heart is still doing what it can do. Okay, it's an opposing force on the outside of the heart causing it to fail. Tension pneumothorax indirectly impairs right ventricular filling by obstructing venous return, and also it can be caused by a large pneumothorax or hemothorax, which there we kind of borderline hypovolemia and obstructive shock. But anyway, so let's look at just tension pneumothorax right now. As that lung drops down and drops down and drops down, and that thoracic area starts filling up with more air. We start shifting that heart around. There's where it becomes tension. We start shifting that heart around. We start compressing the great vessels, your superior, inferior vena cava, more so your inferior, and we start decreasing the preload. We start decreasing the amount of blood coming back to the left ventricle, and that can cause obstructive shock there. Same concept as the pericardial tamponade. Another thing you have to be careful with when you're ventilating your patients and you're utilizing PEEP. PEEP is awesome. I love PEEP. You know that I'm a PEEP fan. However, too much PEEP can kind of do the same thing as a pericardial tamponade, except it's not fluid or air in the pericardial sac. It's pressure increasing inside the thoracic cavity, squeezing those ventricles down. Another one we're going to talk about is pulmonary embolism, PE. This may obstruct lobular arteries and cause impaired systolic contraction. Think of it like this. There's a blockage between the right ventricle and the pulmonary arteries. Not necessarily the pulmonary artery, but it's in the pulmonary artery, and therefore it's causing an increased pressure to remain inside that right ventricle. So therefore we're losing the amount of blood flow to the left, to the lungs and back to the left side. So we're kind of decreasing that preload on the left side, and we're increasing the vascular resistance that the right side must pump against. Well, what do we know about the right side? The right side is not as strong, it's not as muscular as the left side, so PE can throw us into right-sided heart failure. All right. Distributive shock. Distributive shock occurs when peripheral vasodilation causes a decrease in systemic vascular resistance. So what this means is systemic vascular resistance decreases. So what's the easiest way to think about this? The pipes got bigger. Okay? So right now you should already be thinking of some things that can cause vasodilation. The pipes got bigger. Your most common cause is neurogenic shock. And your neurogenic shock is trauma-related, causes massive vasodilation. Another very, very, very common one is anaphylactic shock and septic shock. And we're going to talk about each one of these a little bit more in detail. But those are your common causes. And when I say common, you see them. In your ALS career, you're going to see these, especially nowadays with septic shock. Sepsis is very common nowadays, and the sad part is there's not much we can really do on the EMS side other than provide stabilization support as far as blood pressures and all that. But where we fell on that is we don't realize that the patient is as sick as they are, and then we get them to the hospital and we realize, oh, they were really sick, and could I have done different on this patient? Yes, you could have. We wait for people to get sick before we start treating them. And sepsis is one of those, if you wait too late to start treating the patient, it's just harder for them to recover from this. So in contrast to hypovolemic and cardiogenic shock, distributive shock is a warm shock. So remember we talked about cardiogenic shock. Again, don't get too wrapped up on this. You're just going to hear some people refer to it, and they're not wrong, okay? But warm shock, think of that vasodilation. That blood vessels dilate, come closer to the skin, therefore it is warmer. Same thing when you're hot. Think about when you're hot. That's when you look down at your arms, you see your blood vessels dilated out, and you see the veins in your arms, okay? Warm shock, distributive shock will present kind of the same way. Excuse me. So, neurogenic shock, also known as vasogenic shock. This results from a loss of the normal vasomotor tone due to unopposed parasympathetic response after disruption of the spinal cord, usually at the mid-thoracic level or above. So easiest way to think about this is the body is unable to detect a drop in the blood pressure. Because what's the first response that takes place? The blood pressure, when the blood pressure drops, heart rate increases, right? And then we have vasoconstriction. Well, if the body and the mind, so to say, does not detect a drop in blood pressure, then it doesn't respond to that. And you go back to that compensatory shock lecture that I did, and you talk about your cranial nerves and your chemoreceptors and stuff like that. And it kind of breaks that a little bit more, but basically neurogenic shock is the body does not realize it's in shock. Because of the normal function of the sympathetic nervous system produces vasoconstriction, the loss of sympathetic impulses causes a drop in the vascular resistance, causing massive vasodilation. Therefore, even normal intravascular volumes becomes inadequate. So let's go back to that 5-liter patient. You got to think, in a normal patient walking around with 5 liters of fluid in them, they've got the vasculature maintenance for 5 liters of fluid. Now let's take that 5 liters of fluid that our normal container is equipped for 5 liters, and we blow that 5 liters up to 8 liters. So technically now the body is down 3 liters. Well, in a normal situation, the body would be able to respond to that. Neurogenic shock, it is not able to respond to that. Moreover, the unopposed parasympathetic input to the heart via the vagal nerve leads to bradycardia. So what are some signs of neurogenic shock? Warm extremities, low blood pressure, and bradycardia. Now, I don't like the word bradycardia because people are like, well, I had one and blood pressure was 78 systolic and the heart rate was 64. Okay. Was there any other circumstances that that heart rate should have been 64? Well, what do you mean? Did they take medications? No. Healthy young male. Fell out of a tree stand. That's where we see it a lot, honestly. Okay, so you're taking a healthy young man, fell out of a tree stand, blood pressure is 70 systolic, and you think he's okay with a pulse rate of 64? So don't think that it has to be below 60 for it to be signs of neurogenic shock. Okay? Don't necessarily put your faith in a particular number. Look at what the patient should be doing at that moment. If that patient should be in a compensatory stage, we should see an increase in pulse rate. Now, if they are bradycardia, that's just the textbook symptom. I'm just telling you, don't get tied up and wrapped around the axle when you come in and they're like, oh crap, he's in spinal shock or neurogenic shock. And you're like, well, crap, he wasn't bradycardic. I guess I could have done that different. I don't mean to be ugly, but yes, you could have. All right, anaphylactic shock. This is one that we should be relatively familiar with. Anaphylactic shock will be talked about a little bit more in chapter 26. It is the most extreme form of anaphylaxis. Anaphylaxis may occur when the body is exposed to an antigen, such as any outside force or any outside foreign body, so to say, that produces a severe allergic reaction. The body responds by releasing histamine and other mediators that act on receptors in the systemic and pulmonary microcirculation that produce an effect on the bronchial smooth muscles and the vascular system. So what happens in anaphylactic shock on the bronchial side? It causes massive bronchial constriction or bronchospasm. On the vascular side, it causes massive vasodilation. Histamine causes the arteries and the capillaries to dilate and increase capillary membrane permeability. Remember what I told you about permeability. What's the easiest way to think about permeability? The easiest thing to think of when it comes to permeability is the higher the permeability, the more we allow something to come in. The more permission, permeability, permission for something to enter. We decrease cellular permeability, we decrease the amount that we allow to come in. Intravascular fluid then begins to leak into the interstitial space, causing the edema, thereby decreasing the intravascular fluid. So that's one of the first line treatments following the epi and all that, is we want to give these people large amounts of fluid. So the first thing people say is, well, once we start correcting it, we're going to put them into fluid overload. No, we'll start getting rid of the body fluids. In addition, some of these mediators that are released cause vasoconstriction of the upper and low, constriction of the upper and lower airways, which creates the potential for airway complications. When anaphylaxis progresses to the end stages of cardioregulatory response system, the patient is now in anaphylactic shock. So what's our first line treatments for anaphylactic shock? Want to put them on some oxygen. Want to get some epi, some Benadryl, your H1, your H2 receptors. Antihistamines on board and stuff like that. And again, we'll talk about a separate little video for anaphylactic shock, and we'll get more in depth into the treatments. All right, sepsis and septic shock. Septic shock is a subset of sepsis. So what is sepsis? Sepsis is a systemic inflammatory response syndrome to a known or presumed infection. So there used to be a criteria, and it's still there, where is it sepsis, or is it septic shock, or is it SEERS? So it's like, don't get wrapped up around the axle about that. Just know that sepsis is a systemic inflammatory response syndrome, SEERS, to a known or presumed infection. Now, septic shock is where that progresses into the decreased perfusion to the cellular level, causing hypoperfusion. Okay. This may lead to organ dysfunction and death. This syndrome involves altered function in the major organs and body processes. Septic shock is severe sepsis with profound circulatory, cellular, and metabolic abnormalities. They can cause a greater risk of mortality than sepsis alone. It is diagnosed when sepsis criteria are present and vasopressors are needed to elevate the map above 65 millimeters of mercury or greater. And your serum lactate is greater than 2 millimoles per liter or 18 milligrams per deciliter. Don't get wrapped up. We're not able really in the EMS field right now to do your lactates and stuff like that. However, if you're working in an area where you're going to be transferring patients from small outside facilities to larger inside facilities, that is one of the first things you want to ask for when you're transferring this possibly septic patients. What are our lactate levels? Because lactate tells us a lot. Lactate 1 tells us if they're elevated, what's the byproduct of anaerobic metabolism? Lactate. So if our lactic levels are up, that lets us know that we're in a form of anaerobic metabolism. We need to try to start correcting it. What's the easiest way to correct it? Deliver O2. How do we do that? Make sure O2 is present and get it to the cells. All right. So more than 500,000 people develop sepsis each year, and I would safe to say that's probably increasing now with our pandemics and so on. The screening criteria have been developed for sepsis identification. You can find those online. What I'll do is for Canvas, I'll take that and snap it and throw it online for you. Not worried about you knowing it for testing. You're not going to see it on National Registry, but it is pretty neat to look at. Most criteria include suspected infection of inflammatory response and evidence of poor in-organ perfusion. The most common site of infection include the lungs, the urinary tract, and the skin. Excuse me. Signs of inflammatory response include the SEERS criteria. So pretty much the body is unable to compensate or is overwhelmed by this infection. So you might hear some of the old people said, he's got the blood poisoning, or he got sick and he got the infection in his blood. All right. Sepsis. Progression of shock. Compensated shock. Compensated shock is associated with some decrease in blood flow and perfusion to the tissues, but the compensatory responses of the body can overcome the decrease in available fluid. An increase in catecholamine production maintains cardiac output and a normal systolic blood pressure. All right, so you have that release from your adrenal glands, causing an increase in epi and norepinephrine, therefore causes that systemic response or sympathetic response, an increase in heart rate, an increase in vascular resistance. Depends on what adrenergic receptor sites we're touching at that time, and we get a compensated state. If the shock or if the cause of shock is untreated, compensation will eventually fail. The decrease in perfusion and subsequent increase in acidosis leads to the chemoreceptor response that increases heart rate and depth of, increases rate and depth of ventilation. Again, that goes back to those chemoreceptors and those baroreceptors inside our carotid arteries and our aortic arches. The partial pressure of carbon dioxide causes acidosis, or increase in partial pressure causes acidosis, and that's located in your chemoreceptors. Your sympathetic stimulation increases the heart rate and contractility of the heart, beta 1 receptor sites. And in addition, it causes bronchodilation at the beta 2 receptor sites. You have an increase in peripheral vascular resistance and a decrease in capillary flow in some capillary beds, such as your GI tract. So it causes vasodilation in the GI tract, but causes vasoconstriction in your sympathetic nervous system, and that's your alpha 1 receptor sites. The patient may exhibit delayed capillary refill and cool skin as blood is shunted away from the non-essential parts of the body to the core of the body. Despite maintaining normal blood pressure and urinary output, some patients may show signs of decreased central nervous system perfusion. They might be lethargic, confused, or combative. Now, here's where compensated shock kind of bites us in the butt, because we look at them and go, well, the patient's altered, but their blood pressure's good. And we got this nursing home patient, and they got a Foley catheter, constantly, constant indwelling Foley cath, and they got urine output. So kidneys are perfused, the blood pressure is good, they're not in shock. Well, first off, they got one of the major precursors for septic shock, that indwelling catheter. So what's that urine look like? Is it dark? Is it so on, so on? That's a whole other topic there. But what are we shipping them for? Well, they just don't seem the same. They're just malaise. They're laying around. They're normally in the wheelchair. They're moving around, so on, so on, so on. So now they're just not acting themselves. Guarantee you the person's probably in some form of going towards a shock if it's not a neurological disability. All right. If the underlying cause of shock is, again, left untreated, compensation will fail. Uncompensated shock occurs when the body is no longer able to maintain systemic blood pressure. The systolic pressure usually drops before the diastolic pressure. So that diastolic pressure remains up, but the systolic pressure starts dropping down. There's that narrowing of the pulse pressure, okay? This depends, your systolic pressure depends more on blood volume, and your diastolic pressure may rise at first because of vasoconstriction. Before the diastolic pressure, back it up. Before the systolic pressure can rise, we must have some form of volume returning to the heart. Now, again, we're looking at that preload versus the afterload, and they work hand in hand with each other in maintaining blood pressures. But your systolic volumes are more prominently seen. Systolic pressures are more prominently seen due to blood volume losses. Now, if your diastolic and your systolics are trending kind of close together, then it might not necessarily be a fluid problem. Now, granted, how are we going to treat shock? We're going to treat shock with fluid right out the gate, but we also need to start learning how to react relatively quick to putting these patients on vasopressors. Get out of the habit of we only hang vasopressors when they're really, 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 really sick. Why wait and let patients get sick when we can prevent them from getting sicker? All right. So the decrease in systolic pressure along with maintained and increased diastolic pressure can lead to narrowing pulse pressure, like we just said. So narrowed, in fact, that the pulse pressure is not detectable with the blood pressure cuff. Now, if you get that, if your systolic is so low and your diastolic is still high or low, just your systolic's running down on top of it, that should already be screaming to you right there, we have a problem. As the compensatory mechanisms of the body begin to fail, systolic and diastolic pressures together begin to drop and therefore decrease cerebral blood flow. The partial pressure of oxygen, known as PO2, levels may drop, though the PCO2 levels usually remain normal or low unless the patient has a head or chest injury that leads to hypoventilation. The clinical signs of uncompensated shock include hypotension, tachycardia, tachypnea, delayed cap refill, and decreased urinary output. Excuse me. Shunting of the blood and tissue perfusion, hypoxia may cause the patient to have cold extremities and cyanosis. Effects on the cardiovascular system include a decreased preload and increased rate of contractions caused by catecholamine stimulation. So we're going to have an increase in rate. We're going to have an increase in contraction. So we're going to have an inotropic response and a chronotropic response due to that release of catecholamine. Well, after so long, we're going to have a decrease in that catecholamine release, and we can also start seeing these receptor sites have a decrease of response to those catecholamines. I guess what I'm trying to say. In the late uncompensated stages of shock, myocardial strength decreases as a result of the following factors. You have ischemia, which can result from reduction of circulating red blood cells, a low PO2 level, decreased coronary perfusion caused by hypotension, especially diastolic hypotension when those bottom numbers are starting to trend down. Your cardiodepressant substances that are released, like your myocardial toxins that are released in the ischemic pancreas. We're not getting into those, but they'll cause depression of the heart function in late shock. In the late stages, your myocardial strength decrease can result also from injury to the myocardium. This is essentially stimulating myocardial infarction. It can result associated ischemia from other tissues, causing the damage to the heart itself. You can have decreased preload, which can lead to decreased contractility. Acidosis that can lead to decreased contractility. Your cardiac rhythm disturbances can result from hypoxia, and it can lead to decreased contractility or ineffective contractility also. Irreversible shock. Irreversible shock is the progression of cellular ischemia and necrosis. Remember what necrosis is, that's death. And subsequent organ death becomes irreversible. This is the third and final phase of shock. Despite a return of normal perfusion, patients with massive cellular damage do not survive. Sorry, got sidetracked. Cells and vital organs begin to die from the lack of energy. The membrane pumps fail, and the various organelles in the cell subsequently break down. But as they break down, they become toxic to the body. Thus, necrosis is inevitable, which causes further toxins to be released, and it doesn't matter if we do restore cell perfusion at that time, there's nothing there to perfuse. Decompensation may occur suddenly or may be delayed 1 day to 3 weeks after the onset of shock. So that is why when your patients come in and they're septic and all that, they're monitored pretty closely. Most times they meet a certain criteria, maybe not now with the bed shortages and stuff that we have, but used to, if they were septic, they went to the unit for an extensive monitoring period. The clinical signs of irreversible shock include bradycardia, severe dysrhythmias, frank hypotension, evidence of multiple organ failure, pale, cold, and clammy skin. You will eventually have cardiopulmonary collapse in these patients, and it usually comes on relatively quick once they get into that irreversible stages of shock. All right, last part for this video, variations in the physiologic response to shock. Many variations in the physiologic response occur among patients who are in shock. Determining factors include the following: age, obviously, right? Older adults are less able to compensate. Younger adults are able to, or younger people are able to compensate better. That's why we tell you, children, just because you walk in there and the kid's sitting on the floor playing, don't mean you have a sick kid. I mean, you do not have a sick kid in front of you. Sick kids compensate till they can't compensate anymore. Whereas adults, they compensate for a little bit longer and they begin to decompensate. All right, decompensate until they get to that edge where they flip down and go down, and then we can't bring them back. Children compensate for longer periods of time but deteriorate faster, like I just said. The general health of your patient, the pre-existing diseases and illnesses, other injuries associated with it, and then, of course, pregnancy. You got to think the body now is taking care of two people. Also got to remember, guys, that a pregnant patient, once they become getting sick, what does the body do? It will shunt everything away from the baby, because at that point, it looks at the baby as a parasite, so to say, and it's kind of pulling all the healthy nutrients and more oxygen and all that. So it'll actually shunt away from the fetus itself.